Verbatim, that was the conversation that was had. What's the college going to do about that? You just got $2.5 million, and there seems to be a significant block here. What are you going to spend this $2.5 million that the government's given you? Are you going to have any influence on these log jams in the system that seem to be mitigating people joining?
Well, look, the specific project the college has been asked is separate to that. I mean, it's about educating GPs with to do that. Look, that's certainly an issue that I think would be good to raise with government if that's... But at this point, as I understand it, it's been a soft launch and...
Very soft,
very soft, very soft indeed. And the process is around, testing it at this point. So clearly there's some issues with capacity there that would need to be addressed when they have a harder sell and try to get more of the population involved.
Patrice, as a nurse, are people talking to you about the electronic health record? Do you think there's an interest in it? Do people know about it?
Yes, probably from a practice manager's point of view, they ask more questions, and it would go back to that scenario there where it just gets too hard. So if the patient can't do it for themselves, and they have the conversations that we have, well, if I can't do it and you can't do it for me, I'm not going to do it until it becomes an easy process.
Mark, to what extent have you got any feedback from consumers about this process, about expectations, about mismatch, about what's the story from the front line?
There's still a degree of suspicion and concern about the information that is required. But overall, I think consumers are very supportive of it, that they want a system that they aren't asked the same questions over and over again. They're wanting a system that will actually follow them rather than a system that makes the job of transitioning from one health provider to the next even more difficult. So largely consumers are very supportive of it, and in fact we're concerned that it's taken as long as it has.
And the concerns from consumers about privacy have not been as large as the privacy people seem to be more concerned about privacy than the consumers are.
That's true. There are a number of consumers, particularly people from culturally and linguistically diverse backgrounds, or some Aboriginal and Torres Strait Islander people, or people with special conditions. So some of the people with HIV/AIDS have been concerned about it. But overall, consumers have in fact been very supportive of it.
Ashley, is there a privacy risk legally for the GP?
There's always a risk, so the lawyers say. Look, I think they're just not even from a pure legal perspective, really. When you're dealing with computers and software systems, obviously the security of the data is the key. And we've had for some years privacy principles based on what people are supposed to do with that information. So I think probably the major privacy risk is going to emerge from things like making sure that the information is used correctly and that people who have access to it are properly trained up in how to manage it adequately.
So Sharon comes back after she's registered. How many of you know what to do next? 5, 6, 7 or 8 people? 10%. Let's be generous and say 10% of the audience know. Rephrase the question. Well, she comes in, she's registered. What do you do next? Do you know what to do next?
Before she comes back, so that you're ready.
Well, that's the...
It's before rather than next.
Fine. What do you know? Before she comes back, do you know what to do? So that's still pretty low. And when she comes back, having done what you don't know what to do, about the same number. Ross, do you know what you need to do when she comes back? Or what do you need to do before she comes back, just pick up on Sue's point?
I think the issue here is around trying to make sure that I'm registered and my practice is registered to actually upload the data.
That'd be good.
So I think this is where Sue is going with what we have to do before she comes back. The other bit of that when she does come back is it's very important to actually take the time to go through the existing record that you do have and make sure that it's a reasonable record to upload. You need to have a conversation with with Sharon and Max about what it's going to mean for them to have this record available, and what that's going to mean. What are the benefits to them? Talk about some of the risks. But I think it's very important that you then make sure that what you do upload is somewhat accurate.
John, anything to add to that?
I suppose the only other thing I'd add, obviously, is the requirement that you have the software from your MD, we'll pick a name, Genie, ZMed, that is compliant and capable of providing that service.
So an automated.
The only additional thing that.
So it's a cut and paste, or how does it work if you've got a compliant software system?
Just to rephrase, just to pick up on what Ross said, important you have your data correct. That's fundamental. If that's correct, then depending upon how that software vendor implemented it, it might be as simple as some check boxes to
transfer it across automatically.
Transfer it across into a document that then could be uploaded to the PCHR on that patient's behalf, with them present, with their explicit consent for the information there to be transferred.
And with PIP coming up in May, is it got to be the GP who does that, or can it be the practice nurse or the practice manager?
GP.
Has to be the GP.
Yeah, GP or a RN in certain settings, or an Aboriginal health worker in certain settings. Are the recommended trio of people to take on that task on behalf of the patient.
Talk to me about certain settings.
If you're in certain rural remote settings, there may not be a GP available. Certain people may prefer to see a registered nurse or an Aboriginal health worker for that purpose.
But if you were in Surfers Paradise as a general practitioner and you used your practice nurse to do this, you might be in trouble with Medicare?
Well, if the practice nurse used the system and it had and you were the author of that document, it would depend who the author of the document was. So if you were logged in as Dr. Bennett and you got your practice nurse to do it, you'd have to be fairly trusting of your practice nurse to do that. I wouldn't suggest that would be good practice.
Some of us are that trustworthy, some of us aren't. But I see it as no different from, I wouldn't write a referral on behalf of a GP to a specialist and then have him sign it off. That's your job. That's your work to transfer that record. If it means tidying up a chart and maybe putting in front of someone's nose and saying, you can't send that because half of it's empty, finish your job before it goes electronically.
If I could suggest maybe a way of working together as a team in that context would be...
That's a bit radical.
It is not
too far here.
that maybe they could have a brief consultation with the nurse prior to help clean the data, and then I would be more able to provide them with a quality shared health summary.
Ashley, have you got any concerns about this process? Because error could, with the best will in the world, and Ross is talking about cleaning up the data and cleaning up the records, that's part of the protocol,
Sure.
Error could slip in, and something that's supposed to actually improve quality and safety could harm it.
Absolutely, and they're not the only kinds of error that can be manifest in this kind of system. You can have computer-generated errors, for example. When you talk about data, bear in mind that there's also computer-generated records are not the only records that have errors in them, although that, of course, would have happened to no one here in this room. It is one of the areas in which there is a potential for initial confusion of the records to develop. And, of course, the concern about that is that once it's in there and used potentially by a much larger group of people to make clinical decisions, depending on how far the information goes, it has the potential to be magnified in circumstances where the records might not have gone that far or as many people under a different system.
So presumably, rather than scaring people witless here, if you can show and made a note that you checked the data, went through, and to the best of your knowledge that it was accurate and had a file note to that effect to show that you've done it, that was contemporaneous, then you would be okay. Yeah,
your obligation is to act reasonably or to act in accordance with peer professional standards. It's not to prevent absolutely everything. And a quick plug for the people involved in the conference, the RACGP actually has a really good protocol about this that I managed to find out on the web, but just about having the document trail in relation to the stuff which is uploaded and also having the clear conversations with the people whose records they are about what's going to be uploaded and when, and making sure that there's fully informed consent at as many of those stages as possible, if not all of them.
So, John, Sharon thinks that she can have hospital records on there. When it goes to the physio, the podiatrist, they'll be on. ED presentations, it's all going to be on the record, because she is sick to tired of telling her dad's story, and he's sick and tired of it too. So she's going to get all that?
Probably not straight away. It would depend upon the facility she visited. There's certainly capacity under the current design of the system to do that. A thing called an event summary would allow effectively any health provider who's registered with the system to provide what they think is a summary of the care they'd received. So physio, as you say, could do it, podiatrist could do it, expressly discharge summaries are part of the build for this first system. So it's possible, yes, that's all possible.
But would they have to do double entry? Because certainly in cancer care, the oncologists are saying if we've got to enter it separately and it's not part of our system, we ain't going to do it. We don't have the time.
There's certainly those practical barriers given workflow constraints, time, access to machines within organisations. Yes, that they still have to be overcome. But at least the system, as it's been designed and is being rolled out, will actually allow for that capacity to occur.
So tell me what you do in terms of, if you like, informed consent. Not that it's, you know, you know what I'm saying. You know, setting expectations with patients about what they're going to get if they want to be on it.
Look, yeah, their informed consent process, as I understand it, will be with the government as to what the system would provide. My informed consent requirements would be around the shared health summary, that we agree that the information that I post,
no, I don't understand that, but they come in for you as your friend, their friendly general practitioner who they trust and value. What are you going to say to them that's realistic to be on the record?
Okay, sure. Realistically, that if other providers, and I put myself in that category, if we're able to share information in excess of what the current system allows, hopefully the system on that person's behalf will function better. That's the level of consent I could give them. But
Doctor, what's going to be on it? Tell me what I can have on it now.
Well, all those things could be on it. I guess that would be a discussion they'd have to have with the other providers, what they can offer as part of their clinical services. And if they don't see that as being adequate for their needs, they may need to seek assistance from another provider, which they've done just for me at this consultation. They weren't happy with their previous doctor. They've made a change.
But my dad's on 8 drugs, so and you change one of the drugs. Does that happen? What happens with that?
Well, if it was a significant change, and I guess in that scenario it almost always would be, I would then, again with his consent at the consultation, post a new shared health summary, because that's a very important piece of information to note.
And can pharmacists do it automatically? What about this prescription exchange that we hear so much about?
Yeah, that's coming. That's second release, the prescription exchange work. That won't be visible.
2020, is it? Or?
Hopefully sooner. The question of the medication change, then I guess the other value that we would see for people who have software to view their record is you'll actually see what's been dispensed by the PBS. So I would imagine in his situation you'd be able to see hopefully most, if not all, of the medicines that Max had dispensed on behalf of the government.
Ross, what would you be saying to your patients?
I think you have to be very realistic about what's going to be available on this record at this point in time. I think whatever concerns we have about the quality and the breadth of the data, it's like computerising in your general practice. Bad as it might seem at the start, it's always going to be better than what we had before. So we're going to start hopefully with some very reasonable health summaries, which the patients will have the expectation that when they go to a hospital, when they go to another provider, that they can be accessed. I think there will be significant barriers about the implementation, in that you'll go to EDs and people will not know how to access it straight away, and so there'll be a big learning curve around that. There'll be issues when you go to the physios or the OTs about whether or not they're registered and the time it takes them to log on and see it. But I think over time that the data that's in there and our incorporation of that into our usual pattern of work will be very, very useful. The other part of it is the development of software. I think what we'll see that at the start is that the software that supports it, our clinical software on a desktop, is going to work to a point, but I think what it'll look like in another year or so as that becomes more refined, I think there's a great potential to make it very seamless, and hopefully it's just going to be push of a button, the stuff goes up, and it's there for the patient the next time.
Patrice, what's your take on the software situation in the practice?
I see problems everywhere. I see that general practice will possibly be definitely be the driver with this. It's the other end of the conversation where it's going to stop dead in its tracks. We've got great software packages that we use every day. My understanding of the software that I use is it will be just a bit of a click of a button, but I've got 10 GPs, I hope none are in the audience, who it will take me quite some time to say, just please click that button too. So it's going to be an incremental learning thing, but where I see the big problems are the land of emergency departments and land of specialists who won't have the conversation coming back to us how we want it electronically.
So John, what percentage of the vendor market in terms of penetration of general practices have their software PCHR ready?
I'm not sure the current numbers. I think there's at least... Oh, gee, that's a hard question. I think the big ones are ready to roll now because they need to.
So medical directors now come to the market.
Yes.
Come to the party.
Yes, well and truly, they're in the system, and I think Jeannie and Help Me in Best Practice and almost.
Because medical director was the big one they were holding out.
There had been some issues around contracts on that time, but no, they're definitely there, and they're
so we're not too badly
right
off when it comes to the software.
No.
So
that's looking hopeful.
Mark, how far away from community expectations is the situation we've just been discussing of what's realistically available?
The conversation so far has been a bit disturbing. The website says that the system's ready to go on the 1st of July, which was a couple of months ago. So to hear the stories that have been told at this table, I'm very concerned.